I'm Susan Domchek. I'm the director of the Bassler Center for BRCA at Penn. I am a medical oncologist here at Penn, and I've been running our breast and ovarian cancer genetics program here. I've been here since 2001. And today we had hoped to just do a seminar, identification of individuals at risk for inherited cancer susceptibility. This is going to be focused on breast and ovarian, although I'm going to try to include the common cancers. I'd really love for you to this to be interactive, so feel free to put questions in the chat. So with that in mind, I'm going to get started. We did have some submitted questions ahead of time, and so I'm going to try to tackle those as we move along. Especially, there's interest in the role of the primary care physician. Basically, is it in identification or ordering tests? And I'm going to start by saying that we're happy to help you with whatever you wish to do. We have a lot of expertise in the center. We have a large number of genetic counselors who really have a lot of expertise in this area, and we're happy to sort of help. I'm going to review issues of GINA insurance, this issue of panel selection. Not completely related to this talk, but I had several questions about multi-cancer early detection tests, so I'll reference that as well. And again, feel free to put your questions in the chat. So just to take a bit of a step back, genetic testing has really changed quite a bit, particularly over the last 10 years or so. In 2012, we were mostly doing testing for maybe 2 to 4 genes at a time. And this genetic testing was done by Sanger sequencing. It always involved a blood draw. It was very expensive, several $1,000s. It was time consuming. The tests generally took about 4 weeks to come back. If you were thinking about breast and ovarian cancer in general, testing was for pathogenic variants in BRCA1 and BRCA2. And if you were thinking about colon cancer, endometrial cancer, Lynch syndrome, you were testing for the 4 genes mentioned here, MLH1, actually 5, MSH2, MSH6, PMS2, and EpCAM. But what really happened in 2023, in 2013, things changed significantly. And that was due to the fact that there were patents from Myriad on BRCA1 and 2, and those patents fell. And at the same time, genetic testing, the way to do genetic testing changed. So instead of doing Sanger sequencing, now we use next generation or multi-gene panel testing, which is just a much easier way to do the testing and doesn't require this extensive Sanger sequencing. It's also a lot cheaper. So because of this, we can now sequence 80 genes or more if you like, which I don't necessarily ask you to do. And it can cost either nothing if it's done through insurance or $250 if it's out of pocket. And there are many ways that patients can access this testing, including not going through the healthcare system at all. More testing is not necessarily better. The more genes you test, the more uncertain findings you have. And challenges now remain about things like gene selection. I think that if we were still in the era of sort of testing a few genes, it would almost be simpler. But now we've gotten to a more complex situation. And at the same time that technology has improved with multiple parallel sequencing and costs have fallen, the threshold for genetic testing is continuing to fall. And in fact, there is a really active debate, even as I'm sure you've heard, about whether or not we should do population screening for certain genetic conditions, including BRCA1, BRCA2, and Lynch syndrome. And that is not institutionalized in the United States, but these are issues that are actively discussed. Most insurance companies use what's called the NCCN guidelines for determination of insurance coverage for genetic testing. But again, there are these direct-to-consumer and facilitated options available for patients who want to get testing and they don't need the involvement of their providers. I would like to make a comment, given that 23andMe now has a commercial available for your holiday pleasure of ordering your relatives' 23andMe testing. 23andMe does not do full sequencing for BRCA1 and 2. They do a specific panel of pathogenic variants, which is different than doing full sequencing. And for that reason, negative testing, particularly if not Ashkenazi Jewish, is not useful. And even positive tests come with the caveat that it is meant to be clinically confirmed before action is taken. And so I think that just be cautious of 23andMe testing in terms of those results. And if someone says that they've sent their test off and had it done, it's important to know what lab it was done at. So this is if in some ways sort of the money slide, which is, who should get testing. This is not a comprehensive list. I've really kept this to the most common cancers. Um, so when you look at breast cancer currently, any breast cancer under 50, any individual with metastatic breast cancer, triple negative breast cancer, male breast cancer, or any individual with breast cancer of Ashkenazi Jewish descent. Those all, you don't have to ask any family history. Any of those are eligible for genetic testing. This is likely to continue to fall soon. It's likely that it'll be breast cancer under 65, but I will tell you that the likelihood of finding a very significant finding between 50 and 65 is actually quite low if there's no other risk factors. For colon cancer, again, under 50, abnormal immunohistochemistry staining for mismatch repair, which generally will come up on the pathology report as flagged as an individual who may require genetic testing. Likewise, MSI high tumors or colon cancer in the setting of other Lynch syndrome related tumors. And this is, for your, for those of you reminded of medical school, what those cancers are, you can see here, the endometrial, gastric, ovarian, pancreas, etc. Cancers. For ovarian cancer, it's even easier because it's all epithelial ovarian cancers. For pancreatic cancers, all adenocarcinomas. Prostate cancers, all metastatic prostate cancer, and those listed here. Uterine cancer, any under 50. So you're getting the idea that the guidelines have really widened in terms of who should get testing. And I would say that for other cancer types, just think young onset, pretty much, and anyone under 50, you can at least think about it, except for thyroid and cervical cancers, where they are so incredibly common. Unusual histologies, so pheochromocytomas, paragangliomas, medullary thyroid cancers. Individuals with multiple cancers, those with a very strong family history can all be referred. And basically anybody who would like to get testing these days, we will test. And you can too if you would like. It's just a question of sort of insurance and going through the process of pre-test education. When we're trying to explain what's going on with a family, it's ideal to test individual who has had cancer. And so here's, a pedigree with a family with multiple cases of early onset colon cancer. And the individual that's seeking, who's coming in to seek advice is this individual here who has not had cancer. And given that her father is living, it's ideal to test dad first. This doesn't always happen, and we will still always test the person that's in front of us rather than, if you will, declining a chance to get testing done. But if this individual, if we test this individual first and they're negative, then we don't know whether that's what we call a true negative, which means that the father actually does have a pathogenic variant and our individual is negative. A true negative is extremely helpful and very, very useful for the person who's seeking counseling. And that's a really great result that we like to give people when they're negative for the known mutation in the family. However, if you test this individual first and they're negative, and dad never gets tested, we consider that's an uninformative negative, and we will still recommend that individual get high-risk screening. And this is the reason why we really try to test the affected individuals to give most valuable information to the family. And although this is a little bit basic, just remember there's three possible results. Individuals that test positive, this now we call a pathogenic variant. It used to be a mutation, now it's pathogenic or likely pathogenic variant, sometimes called deleterious, sometimes called a mutation, but the current language is pathogenic variant. negative, which again can be an uninformative negative, which means we can't exclude that hereditary risk, or a true negative where they don't inherit the familial mutation. And then variants of unknown significance. Variants of unknown significance are changes in the genetic code in which we do not know if they affect the function of the gene or not, the function of the protein or not. And there's insufficient data to classify this as either pathogenic or altering the protein, or benign, which would be a polymorphism. And so for that reason, medical management and the relative risk assessment should not be based on this information. Most variants of unknown significance are reclassified to benign, but we can't promise that because about 10% are upgraded. It's also an important thing that if one is ordering testing, one needs to have a way to keep track of this information, as variants of unknown significance are reclassified over time, and the labs provide that information to the provider whose responsibility it is to give to the patients. In general, there's 5 tiers of genetic testing results. Again, negative is there's benign and likely benign, which are the negative results. Pathogenic and likely pathogenic, which are positive results. And then again, these variants of unknown significance that sit in the middle. And interpretations can vary over time and by lab. It's rare, but it does happen very rarely that likely pathogenics are sometimes reclassified to uncertain significance. This is exceedingly rare. I think I've had it seen it happen about twice in my career. Likewise, most of the unknown significance are classified to likely benign, about 10% to likely pathogenic. So someone asked me, in the questions ahead of time, who can order a test? Any healthcare provider can order testing. We have done extensive work at Penn, and led by Kate Nathanson, who I think all of you may know, who is in the division of translational medicine and human genetics. Danielle McKenna, a genetic counselor who works with both Kate and with me, and many others, to work with EPIC and working in the EPIC system to improve things for all of us. And some of these features, which I'm going to show you, include the precision medicine tab. And the point of the precision medicine tab is so that everyone can actually find the genetic test results. I think we all know that, particularly in the past, genetic testing we used to get FedExes sent to us, or with a piece of paper with a patient's genetic test report, which was then scanned into the medical record. This then became a PDF that we uploaded into the chart. And both of those cases just usually were put into the lab section, and nobody could ever find them again. So we've spent quite a bit of time coming up with this precision medicine tab, and we'd also be happy to talk to your administrators in your clinics, because if a genetic testing lab is scanned in as a medical genetics lab, it will go straight to the precision medicine tab and you'll be able to find it again, which is really exciting. We've also done work with HL7 integration with certain labs, particularly Ambry, GeneDx, and Invitae, which means that we order directly through the computer, and that result comes back directly into the computer as a discrete field. This also enables us to do clinical decisions support. And so that's very, very helpful. But there definitely are considerations for pretest education. I'm going to go through some of them. They include the Genetic Information Non-Discrimination Act, implications of the 21st Century Cures Act. There are insurance-specific lab preferences. You have to think about panel selection and again, management of VUSs and uninformative negatives. So just to start with the genetic discrimination concerns, patients do worry about this. There are protections in place. HIPAA is obviously a protection for privacy. There's also the Genetic Information Non-Discrimination Act, and this prohibits the use of genetic information to be used against you for health insurance or your job. However, there is no protections regarding life insurance, disability insurance, or long-term care insurance. Also, the military has very specific issues, which I'm not going to get into here. So this is, we definitely believe that genetic information can be potentially life-saving, but we also, it is true that it's possible that if a life insurance company asks them about this information, they do have to disclose it. And again, in the past, life insurers didn't really ask. Sometimes they ask. It's really hard to sort this out, but it is definitely not covered via GINA. So the 21st Century Cures Act has also added another bit of complexity. This has implications for providers in a few ways. If the direct ordering entry is used so that the result comes directly back into the chart, that is a result that's in there. Now, when we order it, just so you know, we go through a process by which we tell the patient, or we ask the patient if we can hold it and manually release it so that we're able to give them the result. That does mean that you all as primary care doctors might see a result that hasn't been disclosed yet. So this is one challenge, and this is all just happening now. In addition, if you order the test yourself, you have to document if you're doing anything other than auto release in order to be compliant with the law. I do not recommend auto release because the patient does not need to get a result, on a Friday night. We all know how that happens, and genetic testing information is challenging as is. So these are just some things to consider. For those of you who are interested in ordering, feel free to reach out to me. We're happy to help you with this. You can just go into the chart and order. For instance, like this is a breast gyn cancer panel. There is a statement up here that if you have not ordered before, you actually have to create an account with each of these labs. So for instance, Ambry or Invitae or GeneDx. So you have to create a portal entry for yourself, but you can do that if you'd like. There's issues related to, the insurance and the billing. And again, there's this hold for manual release button. So, for now, I'm going to assume most of you want to refer, not order. But for those of you who want to order, again, we're happy to review that. This is an example, and this is now a little bit old, but when we did this Pen Chart Genomics initiative, again, led by Kate Nathanson, the number of tests that we've placed, per month has skyrocketed through the electronic medical record, and the amount of time that we spend either ordering or doing results management has significantly declined. So the electronic health record can be good for some things. When we talk about panel testing, we're talking about, again, going from a couple of genes to many genes. And there are advantages to this, which is, efficiency, reducing time, costs. We can look for more genes at once. We might detect cancer risk that we might not have thought about. And, some patients really do want to go look under every rock. However, when you test for more genes, you definitely have the potential for more uncertainty. We have genes that we don't really know that much about. There's not consensus guidelines. Certainly, the more genes you send, the more variants of insignificance you find. And we can find things that are inconsistent with the family history, which makes it very challenging. And the classic example we give, although we don't find it that much, is CDH1. And pathogenic variants in CDH1 are associated with a very high risk of gastric cancer, such that we recommend prophylactic removal of the stomach. And yet, we sometimes now have found these results in patients who don't have any family history, which raises a lot of challenges about counseling. So there are issues because none of these genes are 100% penetrant. We know that, we're talking about risks, not certainty. We also have initiated these patient-facing genomic indicators, which means that if you have a BRCA mutation, for instance, there'll be clinical decision support triggers about breast MRI and things like that. And this is best rolled out in Lynch syndrome. But these are just other things that you might see in the chart that we're responsible for. But in case you see them there, that's why they're there. And again, this is those issues. So again, if you're interested in ordering, know that providers need to account with the labs. Certain insurers like Cigna requires that a genetic counselor be involved in the ordering of the test. There are tools that are under development through a number of groups at Penn, again, with Kate and myself and others, to develop templates for pretest education. But it is important that if you send testing, I do recommend that you put in language on your discussion, specifically if a patient has not had cancer, reference GINA and the possible results. And I would consider who you're testing. Pre-test genetic testing, pre-test genetic counseling can be extremely valuable for unaffected for pre-symptomatic testing. You know, a 25-year-old with a 50% chance of having a BRCA1 mutation really does benefit from meeting with a genetic counselor. But more abbreviated pretest education, which we've done by video, digital handouts, it can be very effective in situations where testing may change therapy. And we have a lot of experience in that in pancreatic cancers and others. Costs were another question. If individuals meet criteria by NCCN, it often costs nothing. The average cost is $37. There is insurance capitation. The insurance can also have their own criteria that are different from NCCN, and there can be lab capitation. So a classic thing is that if you are actually a Penn faculty member, we have to use certain labs that has Blue Cross, I'm sorry, that we have to use certain labs there. In the Pennsylvania, a law was just passed that will require insurers to cover the cost completely for breast cancer related genetic testing, but that's being rolled out in stages. Also, be prepared for explanation of benefits. The labs eat a lot of the costs. So the labs have this system where they will notify a patient if there's a cost of anything other than $100. And if the lab has not, and they will reach directly out to the patient. So if the lab has not reached out to the patient to inform them that it's greater than $100, it's not going to be greater than $100, even if they get an explanation of benefits from their insurer saying that it's not covered. So the EOBs can be really a bit challenging. All right, here's the precision medicine tab. So this is where we capture things. You can see here, precision medicine, and this is what a lab test will look like that's come in through our through this HL7 integration. So this is a custom Next plus RNA Insight lab, and it says negative. And if you click on this button, it'll pull up all the genes. So it's a lot easier to see than the old system. For those of you who just wish to send patients to us, this is the easiest way to do it. You can check consult to oncology genetics if it's urgent, and usually by urgent we mean that it's a pre-surgical or people are about to like give chemotherapy or something like that to the patient. You can check urgent and say why. Urgents are generally done within 5 days. Routines can take longer. We're working on it. It waxes and wanes. We have 2 people on maternity leave right now. You can check off which is relevant, and also the next button gives you the preferred place, but we cross schedule all the time. And I will tell you that this works. You place this order and we will reach out. We generally do reach out first by My Penn Medicine if they have a My Penn Medicine account. And sometimes your patients don't get back to us, but we do always reach out to them pretty promptly with this. And you can always see that because in the encounters, you'll see notes from my staff reaching out to the patients. And if there's issues, you can let me know. Okay, one more sort of section on sort of questions that were asked in advance, and then I'll go through some more of the gene-specific things. These multi-cancer early detection assays tests. So there are a lot of assays that are being evaluated. The GRAIL Galleria test, sorry about that. The GRAIL Galleria test is the one that's commercially available right now. This is a cancer-specific DNA methylation patterns from cell-free DNA. It is $949, which is just great because it's under $1,000 apparently. It is not covered by insurance. This does not cover the cost of workup, meaning deductibles or copays for the tests that might be done when you have a false positive. I'm going to show you the paper that was just published. The early case control studies look good, but the Pathfinder a study that was just recently published gives you more precise information. They did not report a sensitivity in the paper. Sensitivity meaning the number of tests, the number of patients with cancer that had a positive test. And I think it's because it depends on how you calculated that, how far out. But basically within a year, this test picked up 29% of the cancers. The specificity was 99%. but the positive predictive value was only 38%. So let me take you through that a little bit in more detail, because I think it's important. Oh, well, this is fun because I just went online today, and there are two ways to request Gallery. And the first is you can talk to your healthcare provider, but the second is that you can just click the button and request the test for $949, because an independent telemedicine provider will order the test for you. So patients can do this, on their own. They can, similarly, they can get genetic testing on their own. But again, there's a lot of subtleties with this. So this is the Pathfinder study. This included 6,600 patients. This, again, was recently reported in the Lancet. All these patients came in, they got their blood drawn, they got their assay. So you had about 6,600 patients who had this test was available. 92 of them had a cancer signal detected. Of these, 35 were true positives. On the other hand, you had, 6,500 with no cancer detected. And of these, 86 were false negatives. They ended up with cancers. Okay, so it just gives you an idea. That did pick up 35, excuse me, 35 cancers. So what were the cancers that were detected? Well, a lot of them were lymphomas, Waldenstrom's, and CLL. So you're getting the idea here. And these were all kind of early stage follicular lymphomas. If you go to the solid tumor side, you've got, one, liver cancer, which was stage 1. You've got a small intestine cancer that was a stage 1, a pancreas at stage 2, but the ovarian cancer was stage 3, the prostate stage 4. So what we wanted to see here is a significant shift in stage distribution to early stage. And they do mention, that of the 29 patients with new cancers, 48% were stage 1 or 2, but almost all were, most of them were clustered over here in the lymphomas. So I'm not a nihilist. I think that these tests actually will be useful, but I think that at this point, they have a poor positive predictive value. They actually don't have a great sensitivity, and particularly for some certain cancers. They certainly don't replace screening. But of course, we don't have good screening for ovarian cancer and pancreatic cancer, for instance. So we clearly would like better screening. So I think that, there was another study looking at this particular assay in symptomatic patients in the UK. That was a more positive study, but again, they were already symptomatic. So I think where this is going to fit in is not entirely certain right now. So I'm actually going to look at the chat for a second, because I was going to now go on and talk a little bit more about, so there's a lot of stuff in the chat that is related to the, all that. So I'm not going to ignore that. But if anyone wants to ask a question now, otherwise I was going to give you a little bit more information on genes related to breast cancer in more detail. Okay. Still doing names. Okay, would you recommend Gallery if your patient asks you for it? I really do try to talk them out of it right now. I just think that there are significant downsides to the test. The idea of having sort of a false positive right now and not knowing what you're going to do with that information is significant. It is $1,000, so I know that it's actually $949, but it is expensive. I have not yet had anyone push me too hard on it, but they can order it themselves. So I think that if they're committed to doing it, I'd rather them having done it under your supervision rather than sort of doing it rogue. But yeah, the reps just push back on the reps. And I just think that, I think that ask them about their positive predictive value. I just think that is, and what cancers they're actually detecting. Those are the data that I just showed you. They're talking about like literally one pancreatic cancer was detected at stage 2. The ovarian cancer stage 3. So when they are talking about the cancers that otherwise, don't have screening, well, again, I'm not sure. I'm an oncologist, and I'm not sure that I care that I detected a stage 1 follicular lymphoma. So that's where I stand right now. But on the other hand, we are offering pancreatic cancer screening for BRCA2 carriers, and it involves endoscopic ultrasound and MRI. And I think that that's a lot. And so I definitely want a blood test. And there are some other tests out there that are also being evaluated. And I do think that the combination of methylation assays, potentially these EV assays and other assays are going to get much better, these multi-analyte tests. So more to come. All right, so in terms of BRCA1 and BRCA2, I think everybody's in this call is quite familiar with this, but these are, very significant elevated risks for BRCA1 and 2, lifetime risk of about 70% for breast cancer, mostly triple negative with BRCA1, ER positive for BRCA2, ovarian cancer up to 45% for BRCA1, 20% for BRCA2. And then for prostate and pancreatic cancer, much more with BRCA2 than 1. And the prostate cancer risks are very significant with BRCA2, with lifetime risks, depending on the study of 40 or higher percent. And these are aggressive prostate cancers that the men die of, not with. Now, what has happened, though, is that we know about a lot more genes now. So now it's not just about BRCA1 and BRCA2. There's lots of other genes. And I think one of the first questions to ask is, how commonly are pathogenic variants seen in these genes? And then basically, what do you do? How do you use this information? So we were fortunate enough, Kate Nathanson and I, to be part of this large study that was published in the New England Journal of Medicine about a year and a half ago. This was led by Fergus Couch out of Mayo. And this was a large population-based study of 30,000 cases and 30,000 controls to look at what genes are actually associated with breast cancer and what those risks were. So here you can see that these are the genes that are associated with breast cancer. Any other genes, the association is very tenuous, but there are more genes on this list than you may know about. So here they are. And I think we have more definitive data now to tell you that the prevalence of pathogenic variants in BRCA1, BRCA2, and a gene called PALB2, which is the closest thing we have to BRCA3, the prevalence in unselected breast cancer patients is about 2.5%. But there are two other very common genes, and they are ATM and CHEK2. And pathogenic variants in these genes is another almost 2%. And so these are not at all uncommon. Of note, pathogenic variants in BRCA1 and 2 and PALB2 are about 0.5%. So about 1 in 200 individuals have pathogenic variants in these genes. The other things I wanted to just point out is that the odds ratio in terms of the risk for developing breast cancer with an ATM mutation is about 1.8. And I think you know that having a first degree relative with breast 2. So it's that kind of range. That's in contrast to BRCA1 and 2, where the odds ratios, are 5 to 7. And then for CHEK2, the odds ratio is about 2.5. So these are real risks. They definitely increase the risk of developing breast cancer, but the risks are just modest. Some of these other genes also have, very specific phenotypes. And you might have remembered in medical school, P10 causes something called Cowden syndrome. P53, pathogenic variants called Liefers-Meenie syndrome. These are very rarely seen, as you can see, very rare. Rarely do we find them. And these are very specific phenotypes. Other genes like RAD51C and D have specifically an increased risk of triple negative breast cancer and an association also with ovarian cancer, as I'll show you. This is, again, just a comment on PALB2, which kind of fits around BRCA2 with a odds ratio of about 4. This also just shows you that it depends whether your tumor is estrogen receptor positive or estrogen receptor negative in terms of how likely it is that you're going to find these genes. The reason I pull out BRCA1, BRCA2, and PALB2 all the time is because they're the most important. They're the things that we change management on the most. And so you can get the sense that for estrogen receptor negative breast cancer, that we find them in like 6% of cases, and we find something in about 8%. But ER positive, those numbers go way down. It also shows you here, just in terms of ER negative cancers, that some of these genes are much more important in ER negative cancers than in ER positive cancers. And CHEK2 and ATM, for instance, only increase the risk of ER positive cancer, not ER negative cancer. So they're all just a little different. BRCA1 and BRCA2 and PALB2 kind of cluster, but the rest of them have their own unique features. Just to show that it wasn't just us, this is in the same New England Journal of Medicine article. This is the European study, 60,000 cases, 50,000 controls, the prevalence of pathogenic variants in those three key genes, BRCA1, BRCA2, and PALB2 here, 3%, and CHEK2 and ATM, 2%. So again, if you want to think of, in total, 2.5 to 3% for BRCA1 and 2 and PALB2, 2% for ATM and CHEK2 in your breast cancer patients, that's about where you land. So here's, kind of a little schema here. Genes associated with breast cancer, those that are high risk are BRCA1, BRCA2, PALB2, and then these genes, which are classically syndromic, CDH1, PTEN, STIK11, and TP53, which you're hardly ever going to see. There are these genes that have a more modest risk of breast cancer, again, with relative risks in the 2 to 4-fold range, but more like 2. And that's BARD, CHEK2, the RADs, and ATM. And I think those are really the only important ones. The other ones don't worry about because they're not actionable here, or they are not important at all, which multiple studies have shown. I just throw this out here. For those of you, again, some have commented that they would like to do their own testing, and again, we're happy to help. Just remember that many genes have reproductive implications due to recessive conditions. So for instance, in our ATM mutation carriers, we do counsel about reproductive issues, because if their partner also has an ATM mutation, the baby could have ataxia telangiectasia. So that has to be part of post-test education. Again, we're happy to do that. If you send testing, our genetic counselors are absolutely fantastic and will help with making sure that people understand things. And another side point is just that this genotype phenotype correlation really matters. So specific gene mutations in genes have different implications. This is true even for BRCA, where pretty much all the genes have a very elevated risk. But there's I highlight CHEK2 because you're going to see more and more and more of this, because there are two extremely common founder mutations, CHEK2 I157T and CHEK2 S428F, which are seen in the Eastern European and Ashkenazi populations. But their relative risk of breast cancer is very small, 1.26, 1.3. These are barely breast cancer risk genes, and yet they're super common, and we find them all the time. And we have individuals very concerned about these findings and wanting to do a bilateral mastectomy, even in the absence of family history. And there is where I feel like we're hurting people, because there's not going to be a clear mortality benefit in that case. So I think it's really important to place these kinds of genetic findings in the context of the family history. It's not just about a specific finding. This is just to show that it matters the age. The older you are, the less likely it is that you're going to find a BRCA mutation, particularly if you have an estrogen receptor positive cancer. It's close to sort of the population rate. And if you are 65 or older and have one of these pathogenic variants, your residual lifetime risk of breast cancer is, not very high. Women get these reports, and on the reports, they'll say something like an 80% lifetime risk of breast cancer, but actually it depends how old you are, because if you're 60, though, you're talking about the residual lifetime risk of breast cancer. So even for BRCA1 and 2, if you're 65, the residual risk is in that 20% range to 85. And if you have pathogenic variants in things like ATM here or CHEK2 here, those risks are much lower. So age matters, gene matters, location in the gene matters. Invasive lobular cancers, they're a little bit more likely to have mutations in CDH1, but they're still incredibly rare. 0.2% of invasive lobular cancers will have germline mutations in CDH1. And just because it's really important to address issues of disparities, we know that Black women are much less likely to get genetic testing than white women for all sorts of reasons, but mostly related to the fact that they don't tend to be offered it as much. But the prevalence of pathogenic variants in the carrier study comparing Black women to non-Hispanic white women was really the same. There were some slight differences, slightly more BRCA2, In Black women, less CHEK2, slightly more PALB2, but overall, in Black women, it was 5.6%, and in non-Hispanic white, 5%. And when we actually looked at women diagnosed before age 50, there was no difference in the prevalence of pathogenic variants in Black versus non-Hispanic white women, 8.8 versus 10%. And the individual genes, nothing mattered except CHEK2, which was more common in white, non-Hispanic whites. So race should not matter. It should be, age, triple negative breast cancer, family history that has people getting testing. And, in terms of what we use this information for, we do know that there's, contralateral breast cancer risk. So the decisions about risk-reducing mastectomy can be related to the specific gene. There are other cancer risks. As I'll show you, different genes have different cancers that are relevant, but particularly for BRCA1 and 2, we're talking about ovarian cancer and risk-reducing salpingo oophorectomy. And we have systemic therapy that we do differently in known carriers, particularly BRCA1 and 2 and PALB2, talking about PARP inhibitors and even adjuvant PARP inhibitors, which is a drug that's been pretty amazing and improves overall survival in the adjuvant setting for BRCA1 and 2 related breast cancer. So in terms of contralateral breast cancer risk, and I won't spend too much time on this, but basically ATM individuals who have pathogenic variants in ATM really don't have much contralateral breast cancer risk, but for BRCA1 and BRCA2, they do. And this is, again, age dependent and dependent on, so that means that when I see an ATM mutation carrier who doesn't have a strong family history, the role of bilateral mastectomy here is very uncertain. Of course, there is some risk of developing a contralateral breast cancer, but that risk is low. And similarly for CHEK2, there is some risk, but it's not particularly high. This gives you an idea is that if you look at estrogen receptor, if you had an initial estrogen receptor positive breast cancer and an ATM mutation carrier at 10 years, her cumulative risk of a second breast cancer is 4%. Versus 4.3% in non-carriers and 8% in CHEK2, as opposed to these very high numbers, 17 and 23% for BRCA1 and 2. So again, we really tried to do very specific risk counseling. And these are the other cancer risks associated with these genes that you might be less familiar with. For PALB2, you've got your breast cancer with an associated ovarian cancer risk of, again, like 3 to 5%. So we do talk about oophorectomy, particularly close to menopause in those patients, but not a super early oophorectomy. There is an association with pancreatic cancer as well. ATM, there might be a slight increased risk of ovarian cancer. I hope that goes away with more data. It's very small. It's less than 3%. So we do not recommend routine oophorectomy. For CHEK2, there is no ovarian cancer risk, but there may be a slight risk of colon cancer. That has been conflicting, but the guidelines do recommend enhanced colon cancer screening. For BAR, this is a triple negative breast cancer gene. Again, the lifetime risk of breast cancer is in the 20% range. And RAD51C and D have triple negative breast cancer, but also a risk of ovarian cancer of 10 to 15%. And for that reason, oophorectomy is recommended in those cases as well. So, these are, again, the guidelines, which again, we're always happy we're happy to see patients to review these things in detail, but it gives you an idea of the gene specific recommendations that we have. I do see the question about why do older women why are they less likely to have findings, and it's really just that those are sporadic cancers. We're having the older you are, the more likely it is that you're just having an everyday run-of-the-mill sporadic cancer rather than due to inherited susceptibility. Now, it also is true that, that you've probably heard about these things called polygenic risk scores, which are, genetic modifiers. These are single nucleotide polymorphisms identified by genome-wide association studies. And we know about 300 of them. And if you have all 300 good ones versus all 300 bad ones, your risk is stratified. And you can see how that works in this sort of Bayesian distribution here. And that's true in the general population, and that's also true in individuals who have mutations such as CHEK2 and ATM. And someday we'll be giving very more detailed analysis of by polygenic risk scores, but we don't routinely send these at this time. There's some issues related to ethnicity and how these polygenic risk scores are calculated. There's a lot of, just so you know, we're not trying to be confusing, but we know that it's confusing because there's conflicting guidelines out there. The NCCN, for instance, says test people under 50. ASCO is about to come up with something else. The American Breast Society says all breast cancer patients should be tested. The way that I look at this is some individuals are at much higher risk of having a germline pathogenic variant than otherwise. We know that genetic testing remains underutilized and disparities remained. And I just point out, and this is where we would, love your help with all of this, is that what we find is that people who are tested now, who have cancer now, we're really good. We're able to, because of the way that we're capturing the information, we're able to monitor things really carefully. We know what our uptake is. And so, we're really able to just know that we test, at Penn, if you have a patient with triple negative breast cancer, in the past 5 years, more than 85% of them have already had genetic testing. That's true of ovarian cancer patients too. But if there was a patient that had breast cancer, 15 years ago, and at that time she didn't meet the guidelines, they may not be seeing us anymore. They're seeing you. And so this is why, we're trying to get this word out, about what these guidelines are, and then see how we can be most helpful to you. So again, the genes are different, the variants within the genes are different, and large panels are much more likely to have these variants of unknown significance. So we're happy to talk about this. So these are I just showed you the 12 genes that have been associated with breast cancer risk, and how they differ by age and contralateral risks and things like that. And again, there's a sort of a lot of talk. The genetic counselors I work with are some of the smartest people that I know, and they are incredibly good with patients and very good at taking people through these issues. We also know that that genetic counseling, that there are a lot of patients who went testing, and sometimes it's hard to get an appointment. And so we're happy to help in any ways that people are motivated to do. If you think you'd send testing, a few times a year, it's probably easier to refer to us. If you really want to learn how to do it, we'll help you figure that out. So you can just let me know about that. But it is important to do pre-test education, and it is important that post-test people are captured and they get in for follow-up. Okay. Now, I'm just checking too on the time. I realized that I was going on and on about colon cancer and about breast cancer. I do have some colon cancer slides, but I also want to give time for other questions too. So I'm just going to, just quickly mention that, just as breast cancer has been sort of evolving and growing and becoming more nuanced, so too has colon cancer. And this is beyond Lynch syndrome. We do know, about other genes that can be important, and this is continually evolving, and even down to the types of polyps that are there. So although I kind of mentioned cancer in the beginning, patients with multiple polyps, multiple adenomatous and other polyps also should be considered for genetic testing. We've also become a lot more nuanced in our Lynch syndrome guidelines because it's gene specific. So that's why we've kind of gotten a little bit of, notice I kind of talk about BRCA1 and BRCA2. I wasn't throwing around the term hereditary breast and ovarian cancer because I really think it's gene dependent. For Lynch syndrome, this is still a term that's used because of the tight link between colorectal cancer and endometrial cancer and other cancers. But this does give you the sense that it does depend on the gene, which the highest risk of colon cancer is MLH1 and MSH2, and the lowest PMS2. And we have Bryson Katona leads our GI genetics program, along with our lead counselor there, Jessica Long. So there's a lot of information, we have at Vassar.org, we have information. We have a symposium May 13th and 14th. We have incredible counselors I'm always happy to come speak to anybody about these issues. We have a number of interventions that we're trying to work on to help. Multiple initiatives are underway to help identify patients who are appropriate candidates for genetic testing via the EMR. We recognize that family history isn't captured well in the EMR, and we're trying to do some stuff with that too. But for right now, even just with what we've got in the electronic medical record, we can tell that there are patients out there who are good candidates for testing. We've started some initiatives, and patients are interested in this. And again, we're just trying to help you guys out. We're also trying to do strategies for easier pretest education. And these include my colleague Angela Bradbury has programs called eReach 1, eReach and eReach 2, which are sort of either web versus genetic counselor randomized trial, which is a way to get your patients in too. And this is the contact information. And again, we're helping with integration of these ordering results and clinical decision support, but mostly we just want to know how to help. So again, lots of different things going on at Penn to identify patients, to come up with novel testing methods, and also just improve the standard of care related to documentation and disclosure. Oh, somebody asked me about our vaccine, and so I'll just say briefly, since I don't seem to see questions in the chat, but I am kind of looking. That we have been working on this idea of developing a vaccine to prevent cancer, which sounds, I know, a little bit nutty, but we've been working on this for a while. And this is the prospect of using something called hTERT as a universal tumor antigen. hTERT is the catalytic subunit of telomerase. It's an immunogenic protein that's expressed in nearly all human cancers, but has restricted expression in normal cells. And because it has a key role in oncogenesis, it limits mutation and deletion as a means of immune escape. So we've been using TERT peptides for vaccine approaches in metastatic patients. But metastatic patients have, even though we saw immune responses without toxicity, and the immune responses correlated with overall survival, we didn't see tremendous benefit in those advanced patients. However, a study published, through Penn in 2021 enrolled 93 patients who are at high risk, who had early stage but high risk solid tumors, and they were vaccinated to telomerase because it's a DNA plasmid, and we do with electroporation, which is what this device is, which is a nice way of saying a slight electrical shock, which patients come back and receive all 4 vaccines. 93 patients were enrolled. It was safe, it was immunogenic, and the patients with pancreatic cancer did better than expected with all the usual caveats related to historical controls. That's shown here. Again, this immune response in all the cohorts, and these pancreatic cancer patients doing sort of better than expected with disease-free survival is noted here. So we have, I didn't update this. We have started our telomerase study. This is in individual BRCA1 and 2 mutations. We've enrolled all 16 patients with prior cancer. We have now enrolled 11 healthy BRCA1 and 2 patients and have been vaccinating them. And again, we're hopeful that this will lead to many better things. I'm really grateful because I have this incredible group of individuals that I work with, including the genetic counselors. By the way, I want to mention this. The genetic counselors, you can search for them in the chart by using the filter button, and you'll always see who's been able to see your patient, and you're able to send them messages as well. And they will be able to answer any questions. So with that, I'm going to turn this off, stop sharing, and see if we've got questions for me.
Can you hear me?
Yes, go ahead.
I just have more of a statement. I had actually used my name is Roger, but nurse practitioner at Penn Medicine Limerick. I had actually used the cancer risk evaluation program for one of my patients before. And it was a patient who's had mom had Lynch, grandfather had Lynch, so forth. So what I did was actually simply enrolled him right there at the appointment online, and sure enough, he got a phone call right away from somebody to actually kind of talk to him and kind of bring him down to figure out what's the next step for him. So I was really impressed by that.
Oh, good. I'm glad it worked. I can't say we're 100% on it, but we are really trying, and we have a number of genetic counselor assistants to help triage. So I'm glad that you had that experience. And again, let me know if you don't, because we like to, of course, correct it. Someone asked what age for genetic testing. So it depends on the gene for BRCA1 and BRCA2. The age at which we start doing something different is 25. For things like FAP, it's in childhood. And so it also depends on sort of the ages of cancers in the family as well. But if you're worried about, breast, ovarian, colon, just thinking about it at 25 often makes a lot of sense to send if no one in the family has been tested yet. Let's see. I don't know, my chat kind of went away. Should VUS results also get formal post-test counseling from a gen counselor? There we go. I found my chat. Yeah, for variants of unknown significance, it really is a good idea just to have, if you're sending your own tests, to have us look at those, because sometimes there's discrepancies amongst labs. So we go to a number of different websites. One's called ClinVar, one's called BRC Exchange, and we'll actually investigate the variants of unknown significance to see if they're important or not. That is, that it's another reason though I don't love 80 gene panels, because I don't want to track down every single variant of unknown significance. So the ones that we worry most about are in the high penetrance genes like BRCA1, 2, PALB2, and the Lynch syndrome genes are the ones that we most like. Oh, yeah, that why do older women not have BRCA variants? They can, and I want to be clear about that. It's just that it's because the penetrance is so high. If you get to age 80 and you've not had a breast cancer, because the penetrance of breast and ovarian cancer is so high, you're just less likely to have a BRCA mutation. And that's also true that if you have an estrogen receptor positive breast cancer at 70, it's just much more likely that it's a sporadic cancer and it's not related to a genetic susceptibility. The other comment I just wanted to make about the age of testing, as a reminder, and something I didn't specifically discuss, there is technology now called pre-implantation genetic testing, where individuals can go through in vitro fertilization, screen the embryos, and only reimplant the embryos that don't have a gene mutation. And as you can imagine, this is something that some people are very interested in, others are not. But that is dependent on the age at which people are interested in reproduction. We focused on, breast and ovarian cancer, but I mentioned prostate and pancreatic cancer here. So men, it's important to realize that men have BRCA1 and 2 mutations too. If you line up all the mutation carriers in the world, 50% of them are men. And we do different things for men too. And so, and men can pass along BRCA1 and 2 mutations to their children. So for the men, we don't really do much till like 35 to 40 in terms of their own medical care. But again, it would be important for reproductive decision making. All right. So any other questions? So again, feel free to reach out. Again, if you're interested in again, we're happy to have the genetic counselors come to your practices or things like that. Healthy lifestyle. We generally do counsel, the usual, minimize smoking, regular exercise, minimize alcohol, healthy weight. There is some data these types of things can be protective, but it's tricky. Birth control pills decrease the risk of ovarian cancer. They probably also slightly increase the risk of breast cancer, but it's also not great to have an unintended pregnancy. And so these are all the things that we kind of go through. But the effects of in general, population attributable risks, obesity, diet, exercise, alcohol are incredibly important across a population. To an individual BRCA carrier, they are very modest effects, but they're still good because particularly for a BRCA1 and 2 mutation carrier, we're going to take, unfortunately, we're going to recommend that her ovaries are removed at a young age. That increases, her risk of osteoporosis and cardiac issues. So, that healthy lifestyle is going to be important for those other reasons as well. Okay, with that, we're at time. I wanted to thank you for all your attention. And again, feel free to reach out if I can help. Take care.